From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Clinical Reviews podcast. Thanks for joining us. I'm your host, Dr. Karen Lasser, Professor of Medicine at Boston University and Senior Editor at JAMA. Today, I am joined by Dr. Kylie Cooper, who's an Assistant Professor of Obstetrics and Gynecology at Mayo Clinic, and Dr. Daniel Breitkopf, who is an Associate Professor of Obstetrics and Gynecology, also at Mayo Clinic, and will be speaking about pre-pregnancy care and counseling. You can find a link to the article in this episode's description. Welcome, Drs. Cooper and Breitkopf, to this JAMA Clinical Reviews podcast.
Thank you. It's great to be here.
Thank you so much for having us.
So glad to have you. So to begin with, why is pre-pregnancy care and counseling important? How does it improve health outcomes?
So pre-pregnancy care and counseling encompasses a range of interventions to improve both maternal and neonatal outcomes, while optimization of health and preventative care certainly benefits all people of reproductive age. Having a discussion of reproductive goals and providing individualized education and screening and risk-reducing interventions can certainly support individuals' increased motivation to optimize their health when they're contemplating pregnancy.
And Dr. Breitkopf, did you have anything to add?
Yeah, I think the reduction in maternal morbidity and mortality is really important, and it's just an opportunity to really impact on a future pregnancy if we identify really some very straightforward interventions during the pre-pregnancy period.
Now, with which patients should clinicians discuss reproductive intentions?
It's really important for all patients of reproductive age that could potentially conceive to receive counseling. And so that can be just as basic as, are you planning to become pregnant in the near future, in the next year? Can be a question, and that can be delivered in a number of different ways. But that really is sort of the opening and an opportunity to intervene again on behalf of that patient to improve their pregnancy outcomes.
And for people who are not planning pregnancy, it's also an opportunity to discuss contraception, correct?
Yeah, exactly. And, unplanned pregnancies, as we discussed in the article, are associated with higher morbidity. And so offering contraception and helping the patient plan their pregnancy is really important.
Individuals who have pre-existing health conditions, those are certainly opportunities to be able to counsel and discuss with the patient ways in which we can optimize their disease, discuss medications, and plan for pregnancy. So then they're able to get that information ahead of time and enter pregnancy with open eyes and aware of the potential risks that go along with some of their medical history.
And what are some specific considerations for women with diabetes?
So pre-gestational diabetes, that includes both type 1 and type 2, affects about 1% of pregnancy worldwide, but it does carry a disproportionate risk in terms of congenital anomalies, which can involve the cardiac system and the central nervous system. So some specific considerations for individuals who have pre-existing diabetes are to help optimize their blood sugars prior to conceiving. And ideally, this means obtaining a hemoglobin A1C of less than 6.5%. And that can really help reduce the risk of congenital anomalies. We also think about the other morbidity and organ considerations with pre-gestational diabetes, and that can include retinopathy and nephropathy, hypertension. So aspects that we should be identifying and optimizing prior to them becoming pregnant, as those can further complicate any future pregnancy that they have. So really being proactive and reducing the A1C and figuring out medication changes and optimizing the regimen.
And what are some specific considerations for women with overweight or obesity?
For women with obesity, it's important to plan to bring their weight down to improve their pregnancy morbidity. And there are different pharmacologic interventions that we have, which are certainly effective, and the GLP-1s are one of them. The GLP-1s are tricky in that they are generally not advised during pregnancy, but discontinuing them before pregnancy can also lead to some difficulties during pregnancy, including rapid maternal weight gain and some other concerns.
Yeah, so I would say considerations for individuals with obesity in terms of pre-pregnancy care would be to discuss first-line therapies, which include weight loss and exercise as well, with the goal to hopefully obtain a BMI less than 25 ideally, but certainly any steps towards weight loss can be beneficial. In terms of medications, historically, we've had phentermine and topiramate as options. Those are considered to be contraindicated during pregnancy as they are associated with some teratogenic issues. And so we recommend patients discontinue those a few months prior to attempting conception, ideally. But importantly, the GLP-1 receptor agonists are certainly an important medication in terms of weight loss and are much more commonly utilized. I would say, as with many things in obstetrics, we don't have as much robust pregnancy data in terms of safety on these medications, but certainly they have been shown to be helpful in terms of weight loss, which can improve pregnancy rates and improve menstrual and ovulation regularity, which is very important. And we know that weight loss prior to pregnancy sets an individual up for better outcomes, both maternal and fetal and neonatal. The current recommendation in regards to GLP-1 receptor agonists is that because we are unsure in regards to fetal risks in pregnancies, that patients discontinue those as well prior to conceiving.
Yeah, and I thought it was interesting that your article mentioned that both overweight and obesity are associated with increased risks of gestational diabetes, gestational hypertension, and cesarean delivery. So these things may motivate people to lose weight. But going on to our next question, what are some specific considerations for women with hypertension?
For women with hypertension, there's a recommendation that they bring their blood pressure down during pregnancy to a target of 140/90. And here, some considerations are the medications that are used. So labetalol and nifedipine are typically used during pregnancy, whereas they may not be used typically in the non-pregnant adult. And this is an area where we also want to make sure that we're avoiding potentially teratogenic antihypertensive medications. The ACE inhibitors are sort of one that we classically think of in this population. Dr. Cooper, I don't know if you had anything to add there.
Yes, in terms of cardiovascular disease and hypertension in pregnancy, certainly those are leading causes of maternal mortality and morbidity, and so very important aspects of care. The things we consider in addition to medication management are for patients who have pre-existing cardiac issues, such as a congenital cardiac issue, that we are working together with their multidisciplinary care team, so their cardiology team, internal medicine team, to make sure that we optimize their cardiac status prior to a pregnancy, including imaging, any kind of changes or discontinuation in terms of teratogenic medications, occasionally surgical interventions. So patients are requiring a valve replacement, discussions on timing of that, whether that's something that needs to occur prior to a pregnancy or can wait until later in life. So these are all other aspects that are really important to consider for individuals with pre-existing cardiovascular disease.
Absolutely. And I think one thing for generalists to keep in mind is our usual blood pressure target based on recommendations from the American Heart Association is less than 130/80 for non-pregnant individuals, while the American College of Obstetrics and Gynecology recommends blood pressure of less than 140/90 during pregnancy. But let's move on to discuss another topic. So use of which substances is associated with increased adverse pregnancy outcomes?
So in terms of substances and exposures, we know that nicotine, alcohol, cannabis, opioids, and other substances such as stimulants can be associated with adverse pregnancy outcomes. In thinking about specific risks, we know that nicotine can be associated with preterm birth, small for gestational age neonates, fetal growth restriction. Alcohol can be associated with fetal alcohol spectrum disorders, and cannabis can be related to potentially some longer-term neurodevelopmental issues in offspring. In terms of opioids, we think about concerns for neonatal opioid withdrawal withdrawal syndrome after birth and potentially lower birth weights. And so for all of these, it's so important that we provide screening and brief intervention and referral to treatment to really treat these exposures and substance use disorders prior to a pregnancy for optimal outcomes.
With regards to tobacco use, I think the other thing is that this is a time when people tend to be more motivated to quit and stay quit, an opportunity for the rest of that patient's life to impact their health by offering smoking cessation or tobacco cessation.
Certainly. Now, there's a lot to talk about with people contemplating pregnancy. For example, how should clinicians approach medication review in these patients?
With medication review, we're really looking towards teratogenic medications. There are certainly a number of different resources to identify teratogenic medications and stop those prior to pregnancy. In patients who are attempting pregnancy, generally, we want to stop the medications before they actually conceive.
I would say in regards to medications, just having a detailed review of all medications and all supplements as well in the pre-pregnancy timeframe can be helpful. And this allows for conversations in regards to, do they need to be discontinued? Do we have an alternate option that has more safety data in pregnancy? We do focus a lot on avoiding teratogenic medications, certainly, but generally most medications fall in a gray zone in terms of safety data. And so I think it's really important. It's a nuanced and individualized discussion with the patient in regards to risks and benefits of each medication in terms of their medical history and their disease control and what makes the most sense for them. Because while we certainly don't want to continue teratogenic medications unknowingly, we also don't want to discontinue helpful medications for them out of fear of the unknown in terms of pregnancy. So I think having just a really open, transparent discussion with patients can be very helpful in figuring out for them what makes the most sense in terms of their medication regimen and moving forward for a pregnancy.
Now, can you talk a little bit about intimate partner violence?
Unfortunately, pregnancy-associated violence is a leading cause of maternal death, and I think that's becoming more openly recognized. And so the recommendation is to screen for intimate partner violence in all women of reproductive age using validated intimate partner violence screening tools, which there are a few available, and then certainly to refer them to supports, ideally prior to pregnancy. But it's so important to keep this on the forefront of our minds because it is a huge issue in terms of maternal morbidity and mortality.
But which patients desiring pregnancy should be referred to a specialist in maternal fetal medicine?
Patients that would benefit from referral to maternal fetal medicine pre-pregnancy would be anyone that has pre-existing chronic medical conditions, certainly those with more complex conditions where maybe they're requiring multiple medications for management or there's potential surgical interventions that they need prior to a pregnancy. Any individual or couple that has specific genetic conditions that are heritable, these would all be important, opportunities for discussions and to have a pre-conception consultation with maternal fetal medicine. So with that discussion, we're able to review their medical history, review their medications, review any potential risks that may come up in a future pregnancy that are specific to their condition and how that might manifest, what the risks are, and how that might be managed. And so they have all of that information ahead of time, kind of going into a pregnancy. Certainly, we can never predict what's going to happen during a pregnancy, but at least they have that information and can make informed decisions about whether pursuing a pregnancy aligns with their goals.
The one thing I would add, in addition to what Dr. Cooper mentioned, is that venous thromboembolism and thrombophilia are two sort of high-risk conditions that MFM, maternal fetal medicine, can help with in addition to a hematologist.
Now, which patients should be referred for genetic counseling?
In this situation with genetic counseling, we've moved away from people with specific genetic diseases in their family to offering carrier screening to all couples that are attempting conception, which is relatively new and reflects the advances in technology and the fact that the costs are really coming down for genetic screening.
And I presume primary care clinicians should refer to genetic counselors to do the pretest counseling and conduct the screening, correct?
I think it's still to the point where that is probably the best practice, either genetic counseling or maternal fetal medicine. I'll let Dr. Cooper weigh in on that too.
So the pre-test counseling is so important and to help determine which screening makes the most sense for the patient, what information they are desiring, and how best to obtain that information for them. Ideally, genetic counselors are experts in this. And so if that option is available, that is ideal. But anyone that has training and is comfortable discussing pre-test counseling and testing options, that can certainly include maternal fetal medicine, obstetrician gynecologists, or even primary care physicians if they have some background in that.
Certainly, that's really helpful. Now, I've asked you a lot of questions. Is there anything else you think generalists should know about pre-pregnancy care and counseling that we haven't talked about?
We haven't really discussed folic acid, and I think folic acid is something that's pretty widely known, but is a really important intervention to make sure that everybody is aware of to prevent neural tube defects. I would say, additionally, they're sort of, to me, like the big five to be aware of in patients who are trying to achieve conception. Folic acid, as we just mentioned, immunizations, we talked about weight management, glucose control, and then infectious disease screening. I think if you cover those things in this patient population, you've covered probably 90% of the interventions that can impact on their pregnancy.
And specifically, the vaccination would be for rubella, varicella, and hepatitis B, correct? And we would want to be screening for HIV and syphilis in particular.
Yeah, so vaccination and immunization against infections that can have congenital risks are really important. So that can include, hepatitis B, varicella, and rubella. Make sure that individuals are immune to that prior to a pregnancy. And then in terms of screening for sexually transmitted infections, particularly syphilis, which is increasing in the United States, as well as HIV. And so individuals can be identified and they can be treated so that we can avoid the risks that we think about in terms of congenital syphilis and adverse pregnancy outcomes related to that, as well as the maternal neonatal transmission of HIV. So being able to identify patients, treat them with antiretroviral therapy for HIV can make a huge impact in terms of those risks.
Well, thank you so much. This has been tremendously helpful. I'm Dr. Karen Lasser. I've been speaking today with Dr. Kylie Cooper and Dr. Daniel Breitkopf from Mayo Clinic about pre-pregnancy care and counseling. You can find a link to the article in this episode's description. This episode was produced by Shelley Stephens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.